Teams because it has helped me a lot. So that's a very important part of my journey, FRCR journey. So I think I'll start. We have the first person is you, right, Sabat?
Actually, Nilofer would be first. She wanted to go first. Nilofer, can you unmute yourself?
Yeah.
Okay.
Hi, Dr. Avni.
Hi, Nilofer. So I heard you say that you're doing this for the first time.
Yeah.
So I'll just start sharing my screen. You know how to ask for the control and all, right?
Yeah, I'll ask.
And Sabat, you will be keeping the time.
Yes, I will be.
Great. So I'll just start. Is the screen seen?
Yeah. Yes, it is.
Okay. So we start the time?
As soon as it opens, I'll start.
Yeah, yes. I hope that is okay.
Yes.
Okay, so okay, Nilofer, so this is a patient who has a wound over the forehead and has had a procedure done for that before also.
Okay.
So I think you have the control. You want to start?
Yeah, I've asked.
I have approved already.
Okay. So my images are getting blurry. I'll start.
Yeah.
Okay, so these are the CT brain contrast images in an axial plane. What I can see, there is a large swelling seen in the left frontal region, which is predominantly hypodense and shows peripheral enhancing ring. Also, what I can see, there is a discontinuity in the bone fragment with bone fragments within. So there is a large, small to moderate size collection seen in the left frontal region with peripheral enhancing rim and bone fragments within. So if the patient has been operated.
The patient did have a procedure earlier.
Okay. Yeah, there is a bony defect basically with collection at present. So if the patient is presented with any history of post-procedural pain, fever or something like that or headache, then this could be post-infective procedure, post-surgical collection into it.
This patient has been having the swelling since quite a long time.
Okay.
The procedure was not recent.
So I'll try to look at the other brain window settings, brain images. So on my initial this thing, I cannot see any obvious brain parenchymal abnormality. Only the striking abnormality which I can see, there is a small extradural collection in the left frontal region. Ventricular system appears normal. There is no abnormal focal enhancing mass lesion or any leptomeningeal enhancement noted within the brain parenchyma. So
what
I
do you think it is?
So this could be another thing. It could be like it could be an infective fresh infection. Could be a like Pott's puffy tumor, which could be like tuberculosis in origin due to this chronic.
What is Pott's puffy tumor actually?
So basically, this is an infection of the frontal bone, which is known to occur after any frontal sinus infection. And this leads to this collection and this osteomyelitis kind of picture in the left front, in the frontal bone.
Stop scrolling 1 second. I'll just take the mouse.
Yeah.
You can continue saying. I'll just go to the next case. So what do you think should be done for this case?
So for this, I think I'll refer this patient to the on-call neurology team, and they might take a sampling from this procedure and send for culture sensitivity and treat accordingly for AFB culture and staining.
Okay, this is a patient who has a painful mass in their leg.
Okay. So this is the frontal radiograph of the leg of a skeletally mature patient. What I can see is no obvious fracture or no obvious bony outgrowth or any bony mass lesion is noted. No obvious focal sclerotic or lytic lesion is noted. No periosteal reaction is seen. No obvious soft tissue mass lesion is seen. I think, again, I would like to see the case, and I think there is some linear lucency seen in the metaphyseal region, in the proximal tibial metaphyseal region.
You can leave that.
Yeah, so I think...
that you can leave that.
Sorry?
You can leave that. You don't bother about that.
Okay, sorry.
Pathology is something else.
Okay, so I'll go to see other images also? Or you
Actually,
want
it's
me
more
to...
evident in this.
Okay. What I can see, there is also a small lucent lesion seen in the proximal epiphysis of the tibia, which is lucent and shows, doesn't show any sclerotic rim or any...
Okay, you mentioned some negative findings. Can you just repeat those?
So there is no soft tissue swelling, there is no sclerotic lesion or any bony outgrowth.
Is the fat planes all around in the same way? Is the density all around same?
There is slight increase in density in the mid leg region, in the mid diaphyseal region of tibia and fibula, actually what I can see.
Anything else you're seeing in that region? You mentioned one more negative finding.
Very slight periosteal reaction is noted in the fibula, mid diaphysis, I think. Yes. I'm suspicious of this diaphyseal periosteal reaction.
Okay. So if you see that, what would you want next? What would you... I'll give you another view, but it's not seen well in the lateral, so it wouldn't add much.
Okay.
So what do you want next?
I'll try to see the other orthogonal view. I'll take this.
Okay, you can take it. You can take it. Just click on it.
Okay. This is not of much help. I think I cannot appreciate this thing. So there is basically a periosteal reaction along the diaphyseal region of the fibula. I'm trying to look out for any stress fracture or any soft tissue lesion. I cannot find any bony lesion also in this. So if there is no history of trauma or anything.
Okay, I'll just 1 second. I'll just come back to this. Would you like to comment something about possibly the age of the patient?
This looks like a young adult or young child around 20s, 30s, 20, 25-year-old.
Okay, maybe a bit lower. Yeah, fine. So somewhere maybe in just cross their teenage. It's not completely fused, if you look at it. So anything else you want to think? There is some soft tissue swelling you're seeing. There's some reaction.
So this soft tissue swelling. So this could be, as I cannot see the margins of the lesion, this could be like an aggressive lesion. So I would like to investigate this patient for any malignancy, like some having sarcoma kind of thing, or this could also be an osteomyelitis, but rarely, as it is more on the diaphyseal region.
Okay, so what do you suggest to do
I would
next?
like to compare with any previous X-rays. If
they don't have previous images.
Okay, so then I would like to proceed with patients' any biochemical markers if they're done.
Everything is normal.
Okay, then I would like to proceed with MRI for this patient. MRI for this. Okay.
You can scroll. Which sequence do you want?
Basically, this is T1 weighted image. I would like to see T2 fat set.
Okay, you can take that. Just click on that. Just click on that. Yeah.
Okay. So these are the T2 weighted fat site images. What I can see, there is an abnormality noted in the adjacent muscles of the fibula, which is hyperintense in signal, and there is cortical thickening also noted of the fibular bone. The soft tissue is seen extending into the soft tissue edema. Whatever is seen extending into the intermuscular planes as well. So what I am seeing, basically there is edema in the adjacent bone, adjacent muscles. No collection is noted basically in this. Or I would like to see the post-contrast images as well, if any.
You can take.
Okay, so here I can see peripheral enhancing irregular lobulated collection in whatever those edematous changes I had seen. So peripherally enhancing this region most likely represents an abscess in this region with reactive periosteal reaction in the fibula. So I would like to convey these findings to the on-call.
Just have a look at the coronal images. Just 1 second. Yeah, just. Okay, you can infer whatever you want and tell me.
I'm thinking this most likely to be an aggressive lesion, most likely to be an infective pathology. However, further correlation with USG guided biopsy or aspiration of this lesion needs to be done and to be decided accordingly.
Would you go and put in a needle without knowing what it was? What is your other differential for this?
This could be even having sarcoma also is a possibility in this case, but this kind of a loculated collection, peripheral enhancing collection is rare. So,
okay, so what is next?
Start vessel region, periosteal reaction.
Okay, it's okay. We'll go to the next case. Do you want to continue? Okay, I'll go to the next case. Yeah, this is a patient. They've already, okay, I shouldn't have showed the sequence. Yeah. So this is a patient who has had anemia. This was a case of evaluation for anemia.
So these are the axial images of the CT abdomen and portovenous face. What I can see, there is an enhancing mass lesion seen in the stomach, in the proximal stomach. It doesn't show any necrosis or any calcification within it. So it's a well-defined enhancing mass lesion seen in the, can I take another image?
Yeah.
Along the posterior wall of the stomach. I cannot see any gastric inflammatory fat stranding or spread in this. So this is a single lesion in the stomach with with enhancement. So this lesion at the adjacent wall of the stomach doesn't show any thickening or any abnormality. So I am thinking this most likely to represent benign soft tissue mass lesion. Leiomyomas are more common in this region, but it doesn't show calcification within it, which is characteristic of leiomyoma. However, I would refer this patient for the gastroenterology team for further evaluation with endoscopy and biopsy for this patient.
Leiomyomas tend to be benign, right?
Yeah.
So how does it explain our patient having anemia?
Dr. Avni, sorry to interrupt.
Yeah.
We would make this the last case.
Yeah, sure. Okay.
Thank you.
Okay. For anemia, I'm not finding any cause. Spleen is normal.
Just look at the shape of the lesion. We are anyways wrapping it up. Just look at the shape of the lesion.
Yeah. It is a reniform shaped lesion with the...
How would it ideally look like? It's an ulcerated lesion, actually.
Okay.
Okay, so it could be a source of bleeding.
So
okay,
this could be leiomyosarcoma then.
It could be a plain gist, which is these gist and leiomyomas they can ulcerate.
Okay.
Okay. So so I just start first thing, Nilofer. You should not take the sequences without being asked for.
Okay.
Because you said it's the first time. They are very particular about that. You have to be told what you want. You should ask for what you want. Okay. And rest everything you have handled. This was Pott's Puffy tumor. Okay, but this is, you mentioned this, describe this sequence initially as, you already described it very well. You described everything, all the things you've told, but you're not concentrating on the history that was given. So there was a history of procedure. So initially you were saying that if there was a procedure done, then I would be thinking of this being a procedural change. So yes, it is, there was a history of procedure. So we should be careful. This is a Pott's Puffy tumor. You're seeing there is an extradural collection and extra axial, extra subcutaneous collection. So that you got it right. That was completely right. It was, but in the current picture, we are not seeing any features of sinusitis. So this was totally okay. Then end the case when you tell it, you have got it right, but you have to wrap it up. You have to take it somewhere. You can't just keep it. Actually, you wasted a lot of time. You got the case right, but because you were not ending it, I was not moving to the next case. But because you got it right, you could have just ended it there saying that I'm going to refer it to, say, maybe the neurosurgeons, and it should go. You should end it once you've got it. Okay. This was a difficult thing to pick up. Yes. And there is actually the striking thing is that there is some soft tissue thickening here, and there is this kind of a periosteal reaction. Your differentials were right. But again, once you've got it, you ask for the next thing. Say that you want to move on. Asking for an orthogonal is good, but you have to ask, you spent a lot of time on the X-ray, move on to the next, ask for the MRI, go ahead with it. Okay. Again, you got everything right there. You have described the findings and the differentials are right. But when your differentials are on two extremes, you have to be very careful what you're suggesting. You've already asked me for the biochemical markers. I've already told you the biochemical markers are normal. So then osteomyelitis should go down in your list. Okay. So when we are saying osteomyelitis and we are taking a sample from this, if it's a sarcoma, you're not going to be touching this lesion.
Yeah.
Okay. So that those kind of small things we need to, because it is something you have already asked for and I've already provided you with that history. So you should be, those kind of points should be there in our head because that is what they're leading us on to that. Okay. Otherwise you've got this also right. Then coming to the next one. I think the slides are loading very slow. Yeah, this was a case of an ulcerated gist, and that was we are not seeing any bleeding as such, but this was a case of an ulcerated gist, and this is what is causing the patient to have iron deficiency anemia. Okay. So that shape, because we normally see the gist to be very nice and rounded masses, we don't see these ulcerations. So we just need to be aware of these kind of things. So yeah, I guess this is over. So I think Nilofer, you did well, especially for the first time. You said you're doing it for the first time, so it was good. Okay, and just the thing is, you
so much,
ask for the sequences. Don't take the sequences without being asked, and don't scroll. Multiple times, don't scroll. Okay. Yeah. Sabahat, who's next?
Okay. Thank you so
Yes,
much.
thank you so much. Dr. Saneej?
Here.
Yeah, I'm here. Yeah.
I didn't see you in
Hi,
the
Avni.
list. Hi. Okay. If he's all examining him, yeah. Okay, this is a patient who has some history, but the patient is not aware of the history. Has been under treatment, medical treatment for something.
Okay. So this is a frontal radiograph of the chest of an adult patient who have been on medical treatment for some time. I can see opacity in the bilateral mid zones with well-defined superior and inferior borders, and I can also see that opacity is overlying the cardiac shadow, but cardiac shadow can be separately seen, and I can also see the hilar vessels through that lesion, and there is no rib widening. No, I can also see some lung through that lesion. So this could be a lesion on the chest wall, or this could be a lesion in the pleura, maybe a phantom lesion like fluid collection in the pleural space, or it can be a chest wall lesion. So I would like to see the previous images for comparison if anything is available, and I'd also take it further with a CT scan of the chest for further evaluation.
Okay, if it was a phantom lesion, what would have been the shape and the location of these lesions?
It will be in the fissural region, like in the horizontal fissure or in the oblique fissure usually.
So
But the location is not that ideal. Okay. So it can be.
And a pleural lesion which was this large, would it? You specifically mentioned that there's no bony changes.
Yeah, no bony changes.
So do you expect it to be still pleural?
No. So this could be a actually maybe a posteriorly located mediastinal lesion is also a possibility, or because I can see the cardiac borders clearly, and I'm looking at the spine, and I could not see clearly any spinal
The
pathology.
right lung, what kind of margins is it forming with the mediastinum? The lesion on the right.
It's forming it's acute margins with the mediastinum. Yeah.
So where is the origin? Where could be the origin from?
If it is an acute margin with the mediastinum, this could be this lesions may be cystic, and it can be
Cystic where?
it can be in the
You are right, it is cystic, but where?
for anterior or middle mediastinum is also a possibility, but if there's a lateral view, I could correlate.
No, we don't have lateral view, but on the left side lesion, I can understand it can be a bit confusing, but the right side lesion has acute angles with the mediastinum.
And I can see the hilum overlay sign also, and the
Yes.
cardiac borders are seen.
Okay, you still think it's mediastinum? You want to continue, or you want to?
Actually, I would like to take this further with the CT scan of the chest, and
I don't have a CT. I don't have any images further than this. Actually.
Okay. Then this can be, since it is an acute angle with the mediastinum, this can be a lung pathology also.
Yes. If it is lung, what can it be?
It's an. I'm looking for any. It looks like an airspace opacity, like it's a dense opacity, airspace opacity. So with well-defined margins, it can be.
Okay.
Looks like a mass lesion, but it's bilateral, and.
You mentioned that you can see the lung, what do you call parenchyma through it.
Yeah, so I can see some lung parenchyma. Yeah.
So what does that suggest?
This can be, but I'm not. This can be some. Maybe cystic lesions in the lung, or any.
Like what?
Hydrated cyst is a possibility.
Okay.
Or
It is
or
hydrated
any.
cyst.
Pardon?
It is hydrated cyst. Pulmonary
hydrated cyst.
Yes.
Pulmonary hydrated cyst. Yeah.
And why are you able to see the lung markings through this?
Because there is it's in one lung lobe, and the other lung lobe will be posterior or anterior. So in the right side lesion, if it is in the lower lobe, the upper lobe can be seen posteriorly.
Okay.
Similarly on the left side.
So in case, yeah.
But usually the pulmonary hydrator will not calcify. So I'll inform this to the clinicians and refer to the pulmonology for further management.
Okay, what else complicating features can you expect to see in these cysts? Complications?
There can be a communication with the bronchial tree, and the patient can cough out the contents of the hydrated cyst, and there can be a communication. There can be diaphragmatic and other complications, like it can communicate with the abdomen and other organs, mainly the bronchial communication.
So what will we look for that?
I look at the clinical history, and also
imaging wise.
Imaging wise, I look at the CT scan to see on X-ray. There will be air in the cyst. There will be air, complication of air.
Okay.
Which I'll compare the previous images, and if there is a new onset air in the lesion, it can be suggestive of any communication with the bronchial tree.
Okay. Okay, this person didn't have anything, so you want to do anything further for this, okay?
I will look at the comparison with the previous images and I'll take it further with the CT scan.
Okay. This is the next case. This is an ICU patient who had undergone a procedure.
This is a frontal radiograph chest of an adult patient who is acutely unwell and is in ICU. I can see there is a pleural drainage catheter in situ, pictal catheter in situ on the left side, and the left lung is diffusely abnormal with airspace opacities, diffuse airspace opacities, and there are some and there are multiple lines and tubes seen. These are ECG leads. I think I'm not seeing any. There is a centrally passing nasogastric tube. Maybe it's passing through the midline and going through the left side subdiaphragmatic region. I cannot see that left side of diaphragm clearly. So I presume this patient had gone through a pleural drainage, and I'll compare the previous film if available if this patient had a massive left pleural effusion. If so, this can be a re-expansion pulmonary edema unilateral on the left side, and I'll compare the previous images.
Good. It is a case of re-expansion pulmonary edema. Any other thing you want to mention about the lines and tubes?
I'm looking at the lines and tubes, especially that pleural drainage tube, and also there are some ECG leads, and I can see there is a endotracheal tube in situ. That is predominantly that's above the carina, but that's going to that right main bronchus, mainly towards the right side.
Yes, it is sitting into the right main bronchus.
Yeah. So that I'll inform this to the ICU team to reposition that endotracheal tube correctly.
Okay. So what are the differentials you can think because of which this patient can get re-expansion pulmonary edema?
Apart from that, a unilateral pulmonary edema can happen if this patient is lying on one side and the fluid is accumulating on preferentially on one side. That is one possibility. And second thing will be like in mitral regurgitation and all, you can see unilateral pulmonary edema on the that will be more on the right side. And then this can happen with this type of opacities. This can happen with lymphangitis or any other unilateral pathologies, or any radiation to unilateral lung, or any trauma to unilateral lung.
Okay, I'll go to the next case. This is a patient who came for health checkup.
So this is a frontal radiograph of the chest of an asymptomatic patient came for health checkup. I can see bilateral breast shadows are normal. The CP angles are okay. The heart size is normal. The trachea is midline. I can see some multiple dense nodules scattered randomly in both lungs. This could be. This looks like very dense. This can be healed varicella pneumonia is a possibility. I'll compare the previous images and we'll check for any clinical information whether this patient had any varicella pneumonia, or it can be old healed granulomas also.
This patient had a previous X-ray with the similar images.
So I think this can be a hold varicella pneumonia is a possibility. Healed varicella pneumonia. So
what will you do?
So this is actually need no treatment. I'll compare the previous images, and and you told that it is stable. So this can be if the patient is asymptomatic, nothing is to be done, and I'll report it like that.
Dr. Avni, we will make this one the last case. Okay.
Sure. Okay.
Thank you.
This one, Sanij, is this patient is presented with cough.
This frontal area of radiograph of the chest of an adult patient presenting with a cough. I can see there are bilateral diffuse abnormality involving all the lung zones. There are faint, ill-defined nodules scattered randomly, and the cardiac borders are shaggy, and the diaphragmatic borders are also shaggy, and I cannot see any confluent consolidation or any collapse, and the tracheal bronchial shadow looks fine, and the bones are unremarkable. So I forgot the clinical history. The patient, sorry,
Presented with cough.
cough. Okay. So if this patient is a smoker, this can be um, like the central lobular nodules with some cavitary changes. I am not getting that name. Maybe pulmonary Langerhans cell histiocytosis is a possibility, or it can be. I'm not getting again that name. But if it is a smoker, then it can be that, or it can be other central lobular nodules like. There is some thought process block.
It's okay.
Okay.
Just tell me, what is the distribution you see? Is it like central lobular is still spaced out? How do you think is the distribution here?
There is some relative sparing of the apices, but predominantly it is in the mid and lower zones. So I look at the clinical occupational history of the patient also. If this patient had any occupational exposure to any specific thing, like any occupational exposure.
It's okay. What if this patient, I tell you the patient has cough? So I have told cough. So what if I tell you the patient has fever, cough, and weight loss?
Yeah, then if it is fever, cough, and acutely unwell, it can be miliary shadows of hematogenous spread of tuberculosis, also a possibility if it is acutely unwell, like miliary tuberculosis or.
Okay.
Yeah.
So what would you do next?
Yeah, I'll do a HRCT and will compare the previous images. HRCT chest and.
And the previous images were there was no such finding in the previous images.
Then it's
done, say, 3 months back.
Then it's a newly onset pathology with patient symptoms. So this definitely needs to be evaluated with a CT chest.
Okay. And meanwhile, will you tell them something?
Because if the patient will be infectious, if it is a miliary tuberculosis, no, sorry, patient is to be admitted, and I'll ask for any travel to any endemic areas or any something like that.
Okay, and the patient needs to be isolated. Okay.
Isolated, yeah.
So okay, I can understand the time and that block. So basically,
it's 4:30 early morning 4:30 here, so I'm half asleep.
Yes, I won't blame you for that. Because, yeah, the other one was pulmonary. This is moving slowly. The first one was hydatid cysts. And there is only these pulmonary lesions are there. That is like, you can see multiple and you can still see them so large. So if you see such large lesions in the lungs, we have to keep that. And it's actually having low density contents. That's why we are seeing things through them. Okay, so that is, if we see multiple large lesions, we have to keep that in mind. Rest everything you handled well. Then coming to this, you got it right, except that you did not notice the endotracheal tube. So it is re-expansion pulmonary edema, but you have to mention about the endotracheal tube, which was misplaced. That was also okay. Then this also, yeah, it is calcified varicella pneumonia. So again, it's a leave it alone lesion, nothing to worry about. But these are all classical cases. Yeah, this is not a very good representation, I know, but it is a case of miliary tuberculosis, and especially maybe because of the soft tissue and all, it's not seen so well. But the differentials were okay. LCH, and I think you meant RBILD, if I'm not mistaken.
Yeah, RBILD, yeah. Okay.
So that's okay. That's okay. So it is basically miliary tuberculosis. We have to suggest isolation, and that's it. So, Sabahat, what happens next? Who comes in? Thanks.
I come in.
Okay. Yeah.
Thank you.
Yeah. Okay.
So, Sabahat, do you want me to keep the timer or will you?
If you can. I was wondering if you can.
Okay.
Thank you.
So it's 12.5, right? Okay.
Yeah. So, Sabahat, this is a case, a patient with dizziness.
Okay. Let me ask for the...
you can ask for control. Approved.
Okay. So this is CT scan brain plane of a patient who has presented with dizziness. I'm having a look first, caudocranially. Okay. So the first thing I notice is that there is dilated ventricles. I can see the dilatation of the lateral, the ballooning of the third ventricle as well. The fourth ventricle the fourth ventricle is compressed. This is an unenhanced CT, but I have suspicion that there seems to be a low density area involving this left inferior cerebellar peduncle. In my routine practice, I also look at the coronal and the sagittal images for further evaluation.
Okay, you can take the coronal images.
Okay. I don't know why my mouse is going.
You want me to do it?
No. It's fine. Okay, so I have been provided with the coronal images, which is redemonstrating the dilatation of the lateral and the third ventricles. So this patient presented with dizziness, and there is also widened cell sign gyri, which means that this is, I believe this is an aged patient, but the degree of dilatation of the ventricle seems to be disproportionate to the dilatation of the extraaxial CSF spaces. So I would like to inquire whether this patient has the symptoms of diarrhea, of urinary incontinence and other symptoms as well, because the causal angle seems to be widened, and I'm wondering if this patient has normal pressure hydrocephalus. I would...
you just have a look at the axial images again.
Yes, please.
And,
okay. Okay. So if this is not a patient of NPH, then I would like to take this case further, because I suspect that there is a focal lesion here in the left inferior cerebral peduncle and part of the left cerebral hemisphere with a contrast enhanced CT test.
Where are you suspecting the lesion?
Here, which is compressing the fourth ventricle, I believe.
Okay, so what would you keep in your differential?
Okay, yeah. So in the differential, I would keep, because this is causing a mass effect at the inferior part of the fourth ventricle, I would keep a primary lesion in the differential, as well as a metastatic lesion.
So you're talking about the cerebellar peduncle?
Yes.
Okay, what else are you seeing there?
This is also extending up to some part of the left cerebellum as well. I do not see a lot of edema though. Even the hypodensity is subtle. Okay, what else am I seeing here? I do not see any area of calcification.
Okay, what would be your review areas when you look at brain CT?
So when I'm looking at the brain, I would look at the base of the skull. I would look at the pituitary fossa. Actually, ideally in the sagittal or the coronal images, I would look at the bone windows to see any bony pathology. And I would look at the venous sinuses to rule out any sinus thrombosis. Coming here, and I'm reviewing all those areas actually, but I still haven't found anything significant. But there is something which is causing the pressure effect.
What else can cause compression there? You can.
What else can cause compression here? The herniation, the tonsillar herniation, from the foramen magnum can cause a compression. An abscess can cause a mass effect. What else?
In this particular cut, can you comment on anything that is possibly causing compression?
Yeah, the left cerebellopontine angle is not as clear as the right. So there might be a mass lesion in the left cerebellopontine angle, which could include a wide differential of meningioma or schwannoma or epidermoid, which would need further evaluation with contrast-enhanced imaging, either preferably MRI.
Okay, so I'll give you MRI. Yeah, you can take the sequences as you like.
Okay, so I'll first comment on the T1 axial, which is right now present. I'll go directly to the CPA angles, cerebellopontine angles for the sake of time. What I can see is that there is a T1 isointense lesion, which is present in the left cerebellopontine angle and causing mass effect on the adjacent brainstem. It seems to be widening the internal auditory meatus. I would see it further on T2 and the T1 contrast enhanced images.
You can take the sequences.
Okay, so this is axial T2. So on the axial T2, I can see that there is heterogeneous intensity lesion in the left cerebellopontine angle, which is again enlarging the internal acoustic meatus. And on contrast enhanced, it is showing homogeneous and intense enhancement. I'll just have a quick look at the DWI and the ADC. I believe this should be the DWI. Yes, it is. So it is not showing any restricted diffusion. So I believe with the images which I have seen, this most likely represents an acoustic schwannoma, which is unilateral, because I don't see any such similar lesions on the right side. So I would convey these findings to the neurosurgeon / ENT surgeon, and the patient would be managed by the MDT there.
Okay, you looked at the diffusion. Why did you look at the diffusion?
I just wanted to be sure that this is not a case of epidermoid cyst.
Okay, this patient had a history of fall.
Okay, so this is these are frontal images, frontal and I believe oblique images of the right hand of an skeletally immature patient, which demonstrates fracture through the distal radius. However, I also see a well-defined lucent lesion in the distal radius with a narrow zone of transition. There is no sclerotic border. I do not see, there seems to be some subtle density within this lucent lesion. It is subarticular in location. In a skeletally immature patient, I would keep, there could be a number of possibilities with aneurysmal bone cyst as the prime differential. However, it can also be a simple bone cyst. I would compare this X-ray with the previous radiograph if available, and convey my findings to the orthopedics team for the management of the fracture, as well as for the management of this lucent lesion for future.
Okay. It's taking time to look. Yeah, this is a patient with back pain.
Okay, so this is the frontal and lateral X-ray of the dorsal spine in a patient with back pain. In the first look, I have not been able to identify any gross pathology, so I'll go systematically. I'm going from the first vertebral body, which I can see lower is L2. So I'm looking at the vertebral body heights at their densities at their pedicles. The pedicles and the bone density does seem to be okay. There seems to be some lucent lesion in the midline, but I believe this could be due to gas shadows. I have some suspicion over the medial aspect of the left 12th rib, but again, this could be overlying gas shadows. I would also like, in my routine practice, I also look at the lateral view if it's available.
It is, but you can pick the finding on this. Again, what is your review areas in this?
Okay, so I have looked at I'm looking at the vertebral bodies one by one, and I'm looking at the pedicles to see if there is any destructive process here. On a second look, I feel that there is a lytic lesion involving the D11 vertebral body, with the pedicle here is not very clearly defined. And perhaps I'm suspicious of these lucent lesions also as lytic lesions of the vertebral bodies itself. This patient has presented with back pain. Now, this could have a differential from a destructive lesion by by infection like tuberculosis. However, metastatic lesions like neoplastic lesions can also produce this picture. I would discuss the findings with the clinician and ask if this patient has any acute symptoms of fever, and advise to further take this X-ray with the contrast enhanced MRI of the dorsal spine.
I have CT for you.
Okay. Okay. So what I can clearly see that there is destruction of the posterior aspect of the vertebral body, perhaps D11, along with the destruction of the posterior elements as well. The disc spaces are well preserved. Considering the maintenance of the disc spaces and the involvement of the involvement of the posterior elements by the destruction, I would keep the metastatic lesions as a prime possibility in this patient, and would advise the clinician to do a contrast enhanced pan CT body to find the primary in this patient.
Okay. So from where all can you expect these?
So in this patient, the primary can be if the patient is a female, then breast, otherwise lung in both males and females. Lytic lesion can also be due to renal cell carcinoma, thyroid. So there can be a number of possibilities.
Okay. Again, this next patient is presented with hand pain.
Okay.
So, Avni, this will be the last case. Okay.
Yeah, fine. This is a patient with arm pain.
Okay. So this is the AP view of the right humerus, including the shoulder and part of the chest, in a patient who is presented with arm pain. I'm looking at the humerus first. There is a calcific density near the greater tuberosity, which could be representative for calcific tendinitis. I have suspicion of an lucent lesion involving the diaphysis of the right humerus. Plus, I can see that there is a soft tissue density lesion in the mid zone of the right hemithorax, most likely in the I'm trying to ascertain whether it is in the lung or in the rib, because I can see adjacent destructive lesion, destruction of the rib as well, of the adjacent rib. So in summary, this seems to be a pathology centered in the thorax with metastatic lesion to the humerus. I would convey the finding to the clinician, activate the cancer tracker pathway, and would advise a contrast enhanced CT chest to further evaluate this lesion.
Okay. So you mentioned this. So again, you think it is this to here, or you think it's the other way around? It's the bone lesion which is metastasized to the lung.
Yes, it can be other way around as well, that this is a primary lesion of the humerus, which is giving metastatic lesion, pulmonary metastases. Definitely, this could be also another possibility.
Okay. So I think you got everything fine. Just that you took some time picking that CT brain thing. It's pretty subtle.
Yes.
Right?
No, it should have been picked up. Hot
no,
seat
I think
effect.
you reached there. You know there's something compressing, but it was not so evident. I can understand. Yeah, the history, dizziness also should have been possibly a pointer. So yes. I was actually thinking of not saying dizziness. Okay, yeah. So this you got it right later. This is a CP angle lesion. It was an acoustic schwannoma, so that was done fairly. And Coming to the next case, you mentioned it was subarticular. It is metaphyseal. It's not subarticular.
Yes, you're right.
Okay.
Yes.
So otherwise it was fine. And yeah, this is that winking out sign. So it was a metastatic lesion. Rest you got it right. Which was the other one? The lung lesion with humeral mets. You didn't take time in picking it up, so it was good. So yeah, that's done. So this was a lung lesion which is metastatized to the lung, to the humerus actually.
Yeah.
Okay, so I think you're done with your cases, Sabat. We'll go to the next one.
Yes, thank you so much, Dr. Avni. Dr. Ayaz, can you unmute yourself, please?
Yes, hello. Hello.
Hello.
Yes, Dr.
Dr. Sabha.
Hi,
Hello, Dr.
Ayaz. Hello. So we'll start. I'll show you the next case. You're keeping the timer, no, Sabat?
Yes, I am.
Yeah.
Okay.
Yeah. Yes, please.
Okay, this is a patient, the image when it loads, is a patient with chest pain and dyspnea.
So this is a frontal chest radiograph of a patient who presented with chest pain and dyspnea. The most the striking abnormality which I can see that there is a tubular density projected in the right mid to lower right mid zone region. I don't see any pleural effusion or any other opacity on the contralateral side.
I didn't get Can you
this
please ask
this
for no, I can't see a cursor. Can you ask for this thing? What is it?
You have to ask for the mouse control, Dr. Ayaz. Can you? Are you
okay?
Dr. Ayaz, would you be able to do the hot seat? Is it okay? I know that you are not feeling well.
Yeah, he doesn't sound too okay. Are you okay?
Yes. I'm okay. A little sick. I explained to Sabat that.
Okay.
Yeah, I know, Dr. Ayaz. That's why I'm asking. Are you okay? Would you continue?
Yeah. I will continue.
Okay.
Okay, you continue describing. Leave the remote control.
Yeah.
It's okay. Don't bother.
I can see a tubular opacity in the right mid zone. I can see a tubular opacity, ma'am, in the right mid zone.
Okay, you can leave that. I'm not too sure what you're pointing to. Is it something this or this?
No. This one. This is a.
Okay, you can leave that. That's not the pathology.
Okay. So, the other thing which is which is taking my attention, that the pulmonary artery shadow is there is little bulge in the left pulmonary in the main pulmonary artery shadow.
Yes.
Hello, Dr. Ayaz.
Hello. Yes. I'm audible.
Yeah.
Yes.
So I can see.
Yeah.
the left pulmonary artery, the main pulmonary artery I can see is little prominent.
Mm-hmm.
So I would like to see the lateral view also.
It may not help you a lot. Can you just infer something from this first?
Mm. The left cardiac shadow, I think the left cardiac margin is the left cardiac margin is not normal for me. I'm trying to see that if it is a double left cardiac margin or it is just a bulge. Sorry, I'm not able to make anything, ma'am.
Okay, that's okay. You did mention that you're seeing the bulge in the pulmonary artery region. Do you want to say something more about it? What do you think is causing the bulge or something? Or do you want me to continue to the next case?
Yeah, okay. I can see that there is definitely the pulmonary artery is there is a bulge is prominent. This could represent the pulmonary artery hypertension.
Okay, good. So where do you see pulmonary artery hypertension?
Sorry, ma'am.
Where do you see pulmonary artery hypertension?
Pulmonary artery hypertension we see usually in the setting of
right. This is a young patient.
Sorry.
This is a young patient. Calmness causes.
This is a yeah. That is right heart failure. Usually is the right heart failure or the chronic thromboembolic disease. This in young patient, yes.
Something commoner giving this kind of an appearance. Okay, it's okay. I'll just move on to the next one.
Okay.
This is a patient who has elbow pain. The image that will come up. Yeah.
The patient has, sorry, history. Sorry.
Elbow pain. Elbow pain.
Sorry, ma'am. The
patient is having elbow pain.
Elbow pain. Okay.
Yeah.
Okay. So this is the frontal and the lateral radiograph of a skeletally mature patient. I can see multiple round lucent lesions, which is randomly distributed along the both sides of the joints. I don't see any soft tissue component associated with these lesions. The joint spaces are preserved. So in summary, there are multiple round lucent lesions randomly distributed on the both sides of joint. In a skeletally mature patient, the first possibility for me, it would be the metastasis. It could be from the primary, usually the renal cells, these are not expansile. These no, I will take ma'am. I will take my. I will take little back because these are the lesions with beveled edges. So it could be the eosinophilic granulomas. The second possibility could be the metastasis. So I would contact the clinicians, and I would like to know the if there is any previous imaging available, and I would like to know the clinical data. If there is a concern for the metastasis, I will arrange for the CT chest, abdomen, pelvis, and refer the patient for MD discussion.
Okay. You said eosinophilic granuloma and beveled edges.
Yes.
I'm not too sure what you saw and said. Which age group do you see the eosinophilic granuloma?
Sorry?
Around which age group do you see eosinophilic?
It is in pediatric age group. Pediatric age group.
By seeing this, would you see it's pediatric?
No, this is not pediatric. This is
okay, and it's too many lesions for eosinophilic granuloma. Okay, what else can you put in your differentials other than metastatic lesions?
Multiple lytic bone lesions.
Yeah. What else can come in your differentials? You want to think, or you want me to move on?
It could be multiple myeloma, madam. It could be if the patient is toxic and inflammatory markers are raised. It could be osteomyelitis. Still, if there is any history of it could be lymphoma also. So it is a. I will be guided by the history from the. I will be guided by the history and from the previous imaging, if it is available.
There's no previous imaging.
My differentials actually with this picture will be osteomyelitis or multiple myeloma, but still I will keep the metastasis in my differentials.
Why osteomyelitis?
Yeah, sorry?
Why osteomyelitis?
I mean, these usually the osteomyelitis is a single metaphyseal region. These are multiple, is less likely, but still there is a possibility if the inflammatory markers are raised, if the patient.
Yes, we go to the next, please.
Dr. Avni, I think it's only 10 seconds left, so can we stop here? Thank you.
I'll tell you the feedback of the previous ones. Yes, I hope you're feeling all right. You've been coughing all along.
Yeah, there is some issue little. Anyhow, there is no issue.
Okay. This was a case of ASD actually.
Yeah.
That's a commonest cause, ASD. Atrial septal defect. In young patient, we have to keep that in mind. PH features is a classical features, bulging of the pulmonary conus and hilar prominence, vascular plethora is there. So this is the commonest cause of this young patient.
Yes.
That's okay. We'll jump on to the next. This is, you were going all right till you mentioned about metastatic lesions and multiple myeloma was fine. The moment you said osteomyelitis, you have gone off board, because osteomyelitis can, if it was in one single bone, you can still think of it. It's across the joint space. So unless the joint is involved, the osteomyelitis is not going to come across to the other bone.
Yes.
Is totally fine. So that should not have been in your differentials. Otherwise, it was fine, as long as you had the metastasis and multiple myeloma thing. Okay?
Right.
So I think that's the cases we did. I'll move on. So take care.
Yes. Thank you, Dr. Yas. Get well soon. Dr. Jarvis, can you go next, please?
Yeah, sure, no problem.
Hi, Jarvis.
Hi. How are you?
Okay, I'm fine. Everybody seems to be falling sick these days. Okay, so this is a baby who's a premature baby with respiratory distress.
Okay, I'm provided with a frontal radiograph of a slightly immature patient. It's a baby who presents with respiratory distress. The first abnormality that I can see is is the evidence of granular opacification of bilateral lung fields, and the other thing is that the endotracheal tube appears too highly placed. So the first thing I would do is call the NICU and inform them about my concern for the placement of the endotracheal tube. Then with regard to the lungs, with regard to the lungs, and with the history of a preterm, my primary differential would go in favor of a Highland membrane disease. So I would convey my findings to the concerned pediatrician and inform them about my findings.
Okay. So what you said is okay. You said about endotracheal tube. Is there any other abnormality in the region of the mediastinum that you're seeing that you don't expect normally?
I can see that there's a midline lucency which travels all the way down to the mediastinum. I think that's which appears like the esophagus all the way to the stomach, which appears gas filled.
So what does that mean to you?
So that means it's some can't see an could it be a blind ending pouch which
you did say it's communicating with the stomach.
Yes, it is communicating with the stomach.
Yes. So why would it be there? Why would there be air in the alimentary tract?
It could be because of esophageal intubation of the endotracheal tube.
Yes.
Which could be the primary concern, and so we immediately pick up the phone and call the NICU team and tell them about the malpositioned endotracheal tube and to place it into the trachea as soon as possible.
Okay, yeah. Good. So, what's the basic pathology that happens in Highland membrane disease?
The insufficient surfactant production because of the preterm. So so we provide them with we administer surfactant post birth.
Okay, this is another baby who has respiratory compromise.
Okay, I'm provided with a frontal radiograph of the chest and abdomen of a baby with respiratory distress, with respiratory compromise. The first I can see that the endotracheal tube and the nasogastric tube appear well positioned. There's evidence of an opacification involving the right upper lobe, right upper zone, with giving a right upper zone, which appears to be collapsed. So the endotracheal tube. I would like to focus again on the placement of the endotracheal tube in this patient, as well as I think it is too close to the carina, and I would request the NICU staff to just retract the NICU to retract the ET tube a bit, so that it can be positioned at least 1.5 to 2 centimeters above the carina, and I can also see there's some amount of subcutaneous emphysema along the right lateral chest wall of the patient.
Okay, you can do that. That's okay. So anything else you can see in this X-ray?
Even the left hemithorax appears opacified, and I cannot see the cardiac silhouette very clearly. There is a rounded opacity in the left hemithorax in the midzone, but I think that's a chest lead.
No, that's a chest lead, yeah.
So basically, I would confirm compare with the clinical history of the patient if the patient had was a preterm or a postterm, and
this was a term patient,
and whether there was any kind of a meconium aspiration.
No, there was no such incident reported.
Okay, so.
Okay, anything that you have commented already and you can associate it, club all these findings together? You've actually picked up all the findings. Now you need to club it together and tell me your diagnosis.
Basically, I think there's because of the placement of the endotracheal tube, which is low down, there is some form of right upper lobe collapse. So, uh,
Okay.
which I think that's the one.
Okay. So what would you suggest to do? You told you'll tell them to withdraw. Do you want further imaging after that?
Yeah, a follow-up X-ray would be helpful. Okay, so this is the X-ray taken post after they've withdrawn the endotracheal tube by a few by a few centimeters, and the areas of opacification in the lungs appear to have cleared now. So basically, I think it was due to the malposition endotracheal tube.
Okay. So what all was it causing initially?
It was causing right upper lobe collapse as well as right lower lobe inflation, because of which there was opacification of the left field as well.
Okay, we'll go to the next case.
Okay.
This is an elderly patient who's staying in a mental asylum.
Okay, I'm provided with a frontal chest radiograph of an elderly patient staying in a mental asylum. The first abnormality that comes to my eye is the evidence of a fractured proximal right humerus, and secondly, secondly, they can see a dilated gas-filled viscous, dilated gas-filled viscous below the right hemidiaphragm, causing right diaphragmatic elevation. Um, the gas-filled viscous appears to have hosta, so this appears to look like the part of the ascending a part of the colon. So this could with a uh, and with a history of a mental with a history of staying in a mental asylum, I would think of and considering the old age also, I would like to review the rest to see to take an X-ray of the abdomen and pelvis as well. Okay, so uh, on these X-rays, I can see that that the gas-filled viscous extends all the way from the right iliac fossa, and uh, so this appears to be like a dilated colon all the way. I'm trying to visualize the hernial orifices to see if there is some form of some form of an incarcerated hernia which is causing this kind of obstruction. Um, so I would convey my findings to the concerned physician, and I cannot see any clear-cut evidence of any regular sign or any pneumoperitoneum, but I would suggest for a CT of the abdomen and pelvis to rule out if there was any kind of to confirm my finding of a mechanical obstruction due to a hernia.
So you mentioned a fracture up there. You think
Yes.
it's significant right now?
If I'm thinking about a hernia, no. But if I'm thinking about a malignancy causing this kind of an obstruction, then then I would retract my statement of a hernia causing
No.
this
So
kind of
what
an
are you
obstruction.
thinking?
So then I would if I'm thinking of a malignant stricture causing this kind of a bowel dilatation, it could be a pathological fracture due to metastasis from a colorectal CA.
Mm-hmm. What would you like to describe the fracture again?
The First of all, the fracture appears in the proximal humerus, and there is basically there's no evidence of any periosteal reaction over there. So
Okay. Um, okay. How would you describe? So what is your diagnosis in this? Can you just give
basically,
me?
basically it's colonic obstruction because of either due to a CA or due to a incarcerated hernia.
Incarcerated into what?
Basically a strangulated hernia.
Why did you come up with hernia? You said the hernial orifices were clear.
No, I said I couldn't see any hernial orifices clearly, actually.
So would you still comment about that if you're not seeing the hernial orifice?
Okay.
Okay.
All right.
So we'll go to the next. We'll come back to it later.
Okay.
This is a young child with respiratory distress, maybe a month old or so.
Okay, I'm provided with a frontal chest radiograph of a skeletally immature patient who complains of respiratory distress. The first abnormality that I can see is there's volume loss of the left hemithorax. There is a uh, there's a there's a tube placed in the midline which appears to be located quite proximally at the origin at the probably at the gastroesophageal junction. I would like to confirm whether there was a nasogastric whether a nasogastric tube was placed or no.
This patient had a nasogastric tube.
Okay, so basically, I would call the team and inform them to pull in to advance the nasogastric tube further downwards. And secondly, with regard to the left hemithorax, there's volume loss and there's mild mediastinal shift towards that side. There's the right hemithorax appears expanded, and
Dr. Avni, sorry to interrupt. Just to let you know, this would be the last case.
Yeah,
Thank you.
sure.
I'm sorry, but can I ask the history again, please?
This is a 20-day-old baby with respiratory distress.
Okay. So basically, in this kind of condition, first of all, it's like I would like to tell them to advance the nasogastric tube further, and secondly, I would inquire with the clinical history if there was any if there was any previous X-ray done for this for the baby.
There was an X-ray.
I'd like to
I don't have
compare
it
with
with
those.
me. The appearance was not the same.
Okay.
There was some change in that X-ray
Okay, so
too, but it was not the same.
Okay, so so this represents a sudden change in the in the X-ray appearances, and with the history of sudden respiratory distress, I would think of the possibility of a foreign body aspiration causing
20-day-old.
causing volume loss.
20-day-old.
Okay.
Okay, what if I tell you that there was an area of opacity in this region where you're seeing in the right lung earlier?
In the right upper lobe.
The mid zone. There was an opacity in the mid zone.
Okay. So right middle lobe.
Okay, which area do you think is pathological here?
In the right?
No, which part of this X-ray do you feel is pathological?
I feel there's volume loss on the left side, and there's
Okay.
increased transradiancy on the right.
Do you think both is there?
No, I think there's volume loss on the left side basically.
Okay, so okay, because anyways we are wrapping up with this case, so I think I'll go from here backwards. This is actually the pathology is here. It is congenital lobar emphysema, so the rest of the lungs are normal. In kids, you don't get the proper transradiant appearance, and this is the compensatory. There's some kind of collapse in this region you're seeing because of this emphysematous changes. Okay. So this is the pathological part, not the rest of the lungs. And yes, this is true. Nasogastric tube needs to be advanced.
Oh, okay.
Then the previous X-ray was what?
The mental asylum.
Yeah, you were going in the right way till I asked you about the fracture. Actually, this is an old heel fracture. It's not completely united. It's malunited, but if you look at the margins, it's sclerosed.
There's no periods. Okay.
Yeah,
All
so
right.
don't, just because you're seeing something, you don't need to, get it mixed up. I simply asked you about it. Okay.
All right.
So you don't need to get it mixed up. This was actually a case of pseudo obstruction. Okay, and you do
Pseudo
see it in this,
obstruction.
in this uncared patients and all, you do see this kind of an appearance. Okay, actually, if you look at it, this patient had the flatus tube inserted and this continued this appearance. This is an appearance 2 weeks after the initial presentation. So she had multiple x-rays lined up, all with a similar appearance. It continued and the patient was stable. Okay, so this is, this is the endotracheal tube has been advanced too much. So the left lung and the right upper lobe have collapsed. Because there's selective aeration of the lower lobe and the mid-zone, the middle lobe and the lower lobe. So rest of the things have collapsed. So the left lung was also collapsed. You should have picked it up earlier, but otherwise it was okay. You're taking it well. I mean, you're going step by step, so it's okay. This was, this is not very commonly. We always are used to seeing the endotracheal tube in the bronchus, so we don't really think of this. But with a prompt, you took this well. So this was also good. So, otherwise, it was a Highland membrane disease with the endotracheal tube in the esophagus. Yeah. So that was also okay. So I think you also did well. So Sabahat, who's next? Thanks, Sharon.
Yes. The next is Lela.
Yeah.
Thank you, Jarvis.
Thanks, Sabahat. Thank you. Bye.
Okay, and who is it next?
Lela, can you hear?
Yes.
Okay.
Yes.
So hi, Lela. This is
Hello, Dr.
Hi. This is a middle-aged male who is a smoker.
Okay, so I'm presented with a frontal radiograph of the chest of a skeletal mature male patient, and I can see that there are multiple scattered alveolar opacities, interstitial opacities seen scattered in both lung zones, and there are also nodular shadows seen within. Bronchoectatic changes are also seen. Also, there is a right paratracheal opacity, suggesting that there is also some lymphadenopathy and lymphadenopathy. By looking at the ribs, I find that the ribs are within normal. I don't see any rib destruction or rib mass lesions. Cardiac size is normal. So in summary, and both costophrenic angles are normal as well. So in summary, given that this patient is a smoker, the possibilities for a multiple nodular and interstitial shadows would include a respiratory bronchiolitis ILD. Langerhans histiocytosis is also another possibility.
Any other differentials? You mentioned some other findings also.
Yes, for the lymph nodes as well, I would also be doubtful that this could be related to sarcoidosis maybe.
So how are you going to know what is what?
In that case, first I will check any previous x-rays if there are any previous findings and interval changes. Okay, in that case, then I will refer the patient to the chest physician and request a CT scan of the chest for better assessment.
Okay. You want to ask for
yes,
remote control? Yeah.
Okay. So this is an axial CT scan of the chest, pulmonary window. Okay, and I can see there are lots of reticulonodular interstitial opacities seen in both fields. There is relative sparing of the costophrenic angles. There are no cystic changes to support Langerhans histiocytosis, but I can see that there are right paratracheal lymphadenopathy. In that case, I will be more in favor of pulmonary sarcoidosis. A less likely possibility would be metastatic lymph nodes with secondary lymphangitis carcinomatosis, because lymphangitis carcinomatosis is usually not that symmetrical in appearance.
Okay.
I will also check I'll check the coronal window first for the distribution. So the lesions are basically more in the upper and middle lung zones than in the lower. So in summary, I would still stick to the first initial possibility of sarcoidosis and less likely possibility of metastatic disease. In that case, I will refer the patient to the chest team for further assessment and maybe lymph nodal biopsy, transbronchial lymph nodal biopsy.
Okay. So this next patient presented with right-sided thigh pain.
Okay. So I'm presented with a frontal radiograph of the lower pelvis, basically both hips, of a skeletally mature patient. And I can see that the bony skeleton is heterogeneous with multiple ill-defined sclerotic lesions seen, involving both superior and inferior pubic rami, as well as the both iliac bones and the right neck of femur. The right neck of femur also shows a pathological fracture along its medial border. It is an incomplete fracture, suggesting an insufficiency fracture. I'm not sure if there is another fracture of the left superior pubic ramus. Could be due to positioning.
No, you're right, it's there. So what do you think about it?
So I think given that the patient is an elderly patient, the presence of multiple sclerotic lesions would raise the possibility of sclerotic metastasis, likely
Actually,
prostatic.
that is not really sclerosis. It's just because of the projection and the way it is.
Okay.
That's it.
Okay,
so
fine.
don't bother about the sclerosis.
Fine. Okay. So the presence of the insufficiency fracture in the right neck of
Do you have a
femur.
name for these insufficiency fractures?
Loser zone or milkman's fracture.
Okay.
So that will raise the possibility of osteomalacia in the patient. Accordingly, I will refer the patient to the medical team for assessment of the vitamin D levels and further management.
Where else can you see these loser zones?
I can see them also in both ala of sacrum, giving the Honda sign on nuclear scan. Also in the vertebrae as well.
Vertebrae. Okay. Then, so if you've seen it in the medial aspect now, what if you had seen it on the lateral aspect? Would you call it something else? Or think of some other pathology?
I cannot remember it exactly, but I think
That's
it's maybe related to the, okay.
That's okay. Okay, so this is a patient who's presented with leg pain.
Okay, so this is a frontal radiograph of the right tibia and fibula. And I can see that there is a ill-defined sclerotic lesion seen affecting the upper shaft of right tibia, extending from the metaphysis. I think this is a skeletally immature patient. And the lesion extends from the metaphysis to almost mid-diaphyseal level. It is associated with a small lytic component within, but there is also extensive periosteal reaction in the form of sunray appearance. The presence of extraosseous soft tissue mass is also likely. I'll check the lateral view.
Okay.
So yes, it confirmed, the lateral view confirms the presence of an extraosseous soft tissue components in this region. Accordingly, I'm dealing here with an aggressive mass lesion in a skeletally immature patients. The first possibility would be osteosarcoma. Another possibility would be Ewing sarcoma. So that patient should be referred to a sarcoma center, and for further assessment, he would need an MRI scan of the entire bone for skip lesions and biopsy as well.
So what were the descriptors you used for this lesion?
It is diffuse, affecting the shaft and the metaphyseal region. It has osseous matrix of calcification. It has a aggressive periosteal reaction and extraosseous soft tissue components.
Okay, what did you mean by diffuse?
A diffuse means it's ill-defined with the ill-defined zone of transition, wide zone of transition.
Yeah, so that you would have to specifically mention zone of transition. Okay, so this next patient is a patient who has, okay, I won't tell you the history, you tell me the history.
Okay.
Okay, just see the images, you can pass through the images.
Okay, so this is a non-enhanced CT scan of the brain. And I can see that there is a hypodense lesion seen in the left occipital region. It's cortical and subcortical in location, and I think it's associated with poor encephalic dilatation of the left lateral ventricle, so it is a chronic infarct. There are also bilateral hyperdensities of the globus pallidus.
Okay, this patient has, okay, this patient you described, okay, but this patient had an acute presentation.
Okay. So I'm trying to look for a possible mass effects or effacement, differential effacement of the cortical cell side.
Okay, you said that you saw this patient had this hypodensity in the left occipital region. So what do you think this patient had presented with?
The left side one is an old infarct, so he's probably presented with some visual disturbances. But now I noticed that there is another one which is less hypodense on the right occipital region, and it's not. It's causing some compression on the atrium and occipital horn of the right lateral ventricle. So this could be an acute ischemic insult.
Okay, so which area does that become?
This is the posterior cerebral artery territory.
Okay. Okay, and you mentioned something about some calcifications.
Yes, it's hyperdensities in the both in the globus pallidus bilaterally, as well as in the dentate nuclei of the cerebellum bilaterally as well.
Okay.
This could be because of the patient age. Another possibility could be hyperparathyroidism or FAR syndrome as well.
Okay. Okay, we'll go to the next case. You got this. Okay. So next is a 40-year-old patient who's been undergoing treatment for some reason. Okay. We can go through it. She's now come with loose stools.
Come with, sorry?
Loose stools. Loose stools. It's a 40-year-old female patient.
Okay. So I'm presented with a contrast-enhanced CT scan of the abdomen. It's IV contrast in portal venous phase and the oral contrast as well. And I can see that there is diffuse thickening of the okay, so there is diffuse mural thickening of the small bowel loop seen in the right iliac fossa. Likely this represents a terminal ileum here. There is attenuated lumen and surrounding fat stranding and increased vascularity as well. By checking proximal loops, they are a bit distended. I will look for other lesions. I think there is another lesion here. So we are dealing with skip lesions in the small intestine with one stenotic lesion in the terminal ileum. So these are findings are suggestive of Crohn's disease. I will check the rest of the images. There is also mild hydronephrosis and hydroureter at the right side. This I will have to follow. So the dilated ureter is coursing still here, but it's getting less dilated. It could be implicated in the inflammatory process around the terminal ileum. So this could be the reason for the obstruction, but I don't see any stones. By checking the sacroiliac joints, of course, I will need to check the bone window if there are evidence of sacroiliitis. There is some narrowing of the joint spaces bilaterally, but a bone window will confirm this.
Your thought process is good. But I mentioned that is it a male or a female?
Female.
Female. So I'm just giving you a clue. Do you want to have a look at the pelvis again?
Okay. So I don't see the uterus.
And any evidence of any surgeries?
Yes, there is a sign of a surgical clip on the left side.
Yeah. I said she had a previous treatment history, and now she has loose stools. You would like to put them together?
Possibly that this patient had some past history of inflammatory pelvic inflammatory disease, removing with surgical removal of the uterus and the left tube. Another possibility for this lesion could be the right.
You don't remove the uterus for a PID.
Sorry?
You wouldn't remove the uterus for a PID.
Yes.
So what else would you remove it for?
She could be having malignancy, like endometrial carcinoma or cervical.
Okay, so with that, can you link with the treatment of that malignancy and this current presentation?
With the past history of malignancy, she could be having some local recurrence,
Okay. That's okay. That's okay. I can understand.
This will be the last case, Dr. Avni. Thank you.
So, Leila, you were right. There is a malignancy was there, so they have removed the uterus, but they've given radiation, and this is radiation enteritis. So actually, if you look closely, you're seeing it even the sigmoid colon, and you're seeing this. It is because you've seen it up here. You're suspecting something. You imagined it as Crohn's, but it's actually all around in the pelvis in the region of the radiation zone. Also, if you look at the ureter, it's dilated till it reaches till this point. After that, it abruptly narrows. So that's also because of the radiation. And in fact, CT follow-up after 1 week. I think after they stopped, this is also the dilated 5 months. Yeah. And this is the follow-up one. In this follow-up one, the hydro has come down. And also the thickening, bowel wall thickening and all has come down. So that was a case of radiation enteritis. Then what was the other one you saw? Yeah, this was bilateral PCA, in fact. One is chronic, one is acute. So yeah, that was okay. Visual disturbances history. This is osteosarcoma. That also you got it right. Management was also right, but you didn't start with this being an skeletally immature patient, which was an important point. This also, everything was right. If you see it in the lateral aspect of the femur, if you see the similar appearance, we will think of bisphosphonate.
Okay.
Okay. Then did we, I think we started from this one, na?
Yes.
Yeah, so this was a classical case of sarcoidosis. You got it, you put it as your last differential because you picked the lymph node, it should have been your first differential. That's the only thing. Otherwise, it's all fine.
Thank you so much.
Yeah, I think you did well.
Thank you, Dr.
Sabahat,
Yes. Thank you so much, Dr. Avni. I know it's past 1 in India.
yeah.
Please stop the recording.